Hello everyone, welcome back to NutriMentor. I am Dr. Sayeda Nasreen, Assistant Professor in Nutrition, and in this video series, we are going to discuss an extremely important topic in clinical nutrition and nursing practice, cardiovascular disease, or commonly referred to as CVD. In my previous videos, we have already covered hypertension, and in the upcoming sessions, we'll be discussing obesity and diabetes. Since these conditions are closely interconnected, understanding cardiovascular diseases becomes very essential for you as future nutritionists and nurses. This topic will be covered in three short and focused videos. In video 1, we will be discussing introduction and basic pathophysiology of CVD. In video 2, we'll be covering the signs, symptoms, and risk factors. In the third part, we'll be focusing on the dietary and lifestyle management of CVD. So this series is designed especially for BSc Nutrition and Nursing students, so the explanation will be clear, exam-oriented, and clinically relevant. Let us begin with the very first part of this series, that is Introduction and Pathophysiology of CVD. So, cardiovascular diseases or CVD is a general term used to describe disease affecting heart and blood vessels. The most common type of CVD is coronary heart disease, also known as CHD. CHD mainly occurs due to atherosclerosis, a condition in which fatty deposits accumulate in large and medium-sized arteries supplying blood to the heart muscles. This reduces blood flow to heart and forms the basis for many serious cardiac conditions. Atherosclerosis is the most common type of arteriosclerosis. The term comes from the Greek word scoliosis, which means hardening. It is characterized by the deposition of cholesterol, lipids, and calcium in the walls of arteries. These deposits gradually narrows the arterial lumen, leading to reduced blood flow to the vital organ, especially the heart. The earliest pathological change in the atherosclerosis is the formation of fatty streaks. These fatty streaks can be observed on the endothelial surface of the major blood vessels even by the 10 years of age, showing that the disease progress begins in early life. If risk factors are not controlled, fatty streaks gradually progress to intimal thickening, which refers to the thickening of the inner arterial wall. Conditions such as hypertension, high LDL cholesterol, and low HDL cholesterol promotes the formation of atherosclerotic plaques. As the disease advances, arteries may become narrowed or blocked, leading to reduced blood flow to the heart and eventually myocardial infarction or MI. This diagram shows the stages of atherosclerosis. Initially, the artery is normal with a smooth endothelial lining. The first change in the formation of fatty streak due to the lipid deposition. Over time, these fatty streaks progress to form the atherosclerotic plaques, leading to thickening and narrowing of the artery. In advanced stages, the artery may become severely narrowed or blocked, significantly reducing blood flow and increasing the risk of cardiac events. American College of Cardiology has classified cardiovascular risk factors into 4 categories. This classification helps in matching the intensity of risk factor management with the strength of scientific evidence. Category 1 risk factors are those where interventions have been clearly proven to reduce cardiovascular disease risk. Category 2 risk factors are those where interventions are likely to reduce risk based on available evidence. And category 3 risk factors are those where more research is required to confirm whether intervention is beneficial. Category 4 risk factors include factors that cannot be modified, such as age and genetic predisposition. Category 1 and Category 2 include modifiable risk factors where lifestyle changes and medical intervention can reduce disease risk. Category 3 risk factors are also potentially modifiable, but strong evidence is still lacking regarding the benefit of intervention. Category 4 includes non-modifiable risk factors such as age, gender, and genetic predisposition, which cannot be changed. From a nutrition and nursing perspective, management mainly focuses on category 1 and category 2 risk factors. Atherogenesis refers to the process of formation of an atherosclerotic plaque. The process begins with the injury to the endothelial lining of the artery. This injury allows LDL cholesterol to infiltrate the arterial wall where it undergoes oxidation. Immune cells, particularly macrophages, take up the oxidized LDL and transform into foam cells, which accumulate in intimal layer. Over time, the accumulation of foam cells and smooth muscle cells lead to plaque development and narrowing of the artery. Because immune cells are actively involved in this process, atherosclerosis is now considered a chronic inflammatory disease and not just a lipid disorder. The atherosclerotic process begins early in childhood and usually takes several decades to progress to clinically evident disease. The pathogenesis of atherosclerosis is multifactorial, meaning that multiple factors contribute to its development. The lesions formed are results of proliferation of smooth muscle cells, macrophages, and lymphocytes, which are cells involved in the inflammatory response. These smooth muscle cells form a connective tissue matrix within which lipids and cholesterol accumulate. The lipid deposits, along with the cellular debris, calcium, and fibrin that collects in the intimal layer of the artery, together form what is known as atheroma or atherosclerotic plaque. So, phases of atherogenesis. So phase 1 is usually asymptomatic and is characterized by fatty streak, which is non-obstructive lipid-filled cells. In phase 2, fatty streaks progress to form lipid-rich plaques derived mainly from LDL cholesterol. These lesions are considered unstable. Phase 3 involves plaque rupture with formation of non-occlusive thrombus. In phase 4, an occlusive thrombus is formed with significantly reduced blood flow and is clinically associated with angina and myocardial infarction. The slide illustrates the development of atheroma following endothelial injury. LDL cholesterol enters the arterial wall and undergoes oxidation. Macrophages takes up this oxidized LDL and form foam cells which accumulate within the intimal layer. Over time, smooth muscle cells and connective tissue surround these lipids deposit, leading to formation of atheromatous plaque, which gradually narrows the arterial lumen. This reduced blood supply results in myocardial ischemia, meaning inadequate oxygen delivery to cardiac tissue. If the narrowing becomes severe or if a plaque ruptures suddenly, it can lead to angina or myocardial infarction. With this understanding of the disease process, we can now move on to the clinical features and risk factors of the cardiovascular diseases in the next video. So stay tuned for part 2. Thank you very much.